Good evening, ladies and gentlemen. Tonight we will be reading a research journal, which is for Monday, called Incentivizing Safe Sex, a randomized trial of conditional cash transfers for HIV and sexually transmitted infection prevention in rural Tanzania. Now, I've heard that this isn't the most fun article to read, given that it's quite heavy on the algebraic and obviously econometric side. So I'm going to probably breeze through the statistical sections and focus more heavily on the parts that are analyzing and interpreting these results. Because if you really want the numbers, you can look them up for yourself. But I believe that the point of this course is to be teaching us about the purpose and the reasoning under which econometric analyses are undertaken, as opposed to the actual numeric values found in the tables here. But obviously, you'll be able to access it yourself if you want to look at it in more detail. Anyway, without further ado, let us begin. Abstract. Objective. The authors evaluated the use of conditional cash transfers as an HIV and sexually transmitted infection prevention strategy to incentivize safe sex. Design. An unblinded, individually randomized and controlled trial. Setting. 10 villages within the Kilombero/Ulanga districts of the Ifakara Health and Demographic Surveillance System in rural southwest Tanzania. Participants. The authors enrolled 2,399 participants, aged 18 to 30 years, including adult spouses. Interventions. Participants were randomly assigned to either a control arm, N equals 1,124, or one of two intervention arms, low-value conditional cash transfer, eligible for $10 per testing round, N equals 660, and high-value conditional cash transfer, eligible for $20 per testing round, or N equals 615. The authors tested participants every 4 months over a 12-month period for the presence of common sexually transmitted infections. In the intervention arms, conditional cash transfer payments were tied to negative sexually transmitted infection test results, obviously. Anyone testing positive for a sexually transmitted infection was offered free treatment, and all received counseling. Main outcome measures. The primary study endpoint was combined prevalence of the 4 sexually transmitted infections, which were tested and reported to subjects every 4 months: chlamydia trachomatis, Neisseria gonorrhoeae, Trichomonas vaginalis, and Mycoplasma genitalium. The authors also tested for HIV, herpes simplex virus 2, and syphilis at baseline and month 12. Results. At the end of the 12-month period, for the combined prevalence of any of the 4 sexually transmitted infections, which were tested and reported every 4 months, see trachomatis and gonorrhea, blah, 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 you know the diseases, unadjusted for RR, the high-value conditional cash transfer arm compared to controls was 0.8, which is 95% CL 0.54 to 1.06, I don't know what that means, and the adjusted RR was 0.73. Unadjusted RR for the high-value conditional cash transfer arm compared to the low conditional cash transfer arm was 0.76, and the adjusted RR was 0.69. No harm was reported. Conclusions. Conditional cash transfers used to incentivize safer sexual practices are potentially a promising new tool in HIV and sexually transmitted infections prevention. Additional larger study would be useful to clarify the effect size, to calibrate the size of the incentive, and to determine whether the intervention can be delivered cost-effectively. Article summary. Article focus. Existing prevention strategies had a limited impact on the trajectory of HIV/AIDS epidemic. Conditional cash transfers have been used successfully in a variety of settings to promote activities that are beneficial to the participants, such as school participation or health checkups for children. This trial asks whether conditional cash transfers can be used to help prevent people from engaging in activities that are harmful to themselves and others, such as unsafe sex. Got to beg the question, why don't they just give out a ton of condoms? I know that's awfully simplistic, but, having given them the money, beyond that, you've already given them an immediate reward. I feel that for something as, I don't know what word you want to call it, primal or fundamental of human behaviors as sex, that people would kind of not give a shit if you've given them money about, they wouldn't care about the potential to not gain that money in the future because it's something they'll want to do anyway. Does the paper look, I mean, this is me speaking up as as someone who is very interested in the sort of social and cultural aspects of the of this kind of phenomenon. Obviously, I'm not by any means suggesting that this is some kind of ridiculous test that doesn't have any bearing on reality, but I'm asking if there's more to it. But anyway, I'm not going to go off on too much of a tangent, because obviously the point of these readings is not for me to give my interpretation every 10 seconds, it's for me to actually read it, so I will now carry on. But I do think that there's more to it than just, if you pay them money, they'll stop having unsafe sex. I can definitely see there's some logic to it, in that assuming that condoms are readily available even in remote areas and so on, or any other kind of contraception that would prevent the transmission of sexually transmitted diseases, assuming they are available, then yeah, it would obviously make sense for people to use them. But they have to factor in the cost of how much they would spend on contraception given the $10 payments or whatever. Because if it's after 4 months, I'm going to be real here, assuming contraception isn't free, which I doubt it is $10 going to cover 4 months worth of contraception? And if that's not the case, then it's fundamentally kind of a dumb payment, isn't it? However, on the flip side, I've also got to ask, what kind of level of understanding, of education is there regarding sexually transmitted diseases in that country? Are they aware of the threat to their health that stuff, for instance, like HIV presents? Because obviously here in the West, we are in a position of incredible privilege. Not only does HIV is fairly rare compared to obviously Tanzania, but in addition to that, we are very much aware of the risks associated. It massively debilitates your immune system, and it reduces your life expectancy by orders of magnitude, even with the modern healthcare that we have in our countries. So really, it's a much more complex issue than simply, can you give out money to help reduce STIs or HIV. However, obviously this paper can only focus on one small area. They've only got so much funding, so it makes sense that this can't encompass everything. But I'm just giving my thoughts on all the other aspects. You'll appreciate that I tend to ramble a little bit more as it gets later into the night. It's only 9 p.m. right now, but it is going to drive me absolutely insane if I just read out these papers without giving my own thoughts on it, partially because I like talking about thoughts and opinions and stuff, because I'm quite opinionated, but also because if I just behave like a robot and regurgitate the words that are on the page, I will go absolutely batty, and I don't want that. So, it is also my hope that if I'm not just reading out everything in some sort of monotone, that it'll be slightly more interesting for you to listen to. But again, I'll try and keep these to a minimum. So here I've gone off on a sort of 5-minute tangent, but for the rest of the paper I intend to obviously not go off on a diversion like this for more than a minute or so. Anyway, let's carry on. So, key messages. We designed and evaluated a novel intervention that tests for risky sexual behavior repeatedly over short time intervals, reinforcing learning about safer behavior with cash transfer incentives conditional on testing negative for a set of curable sexually transmitted infections. After 12 months, the results from the adjusted model showed a significant reduction in the combined point prevalence of the 4 curable STIs tested every 4 months by nucleic acid amplification tests in the group that was eligible for the $20 payments, but no such reduction was found for the group receiving $10 payments. The results suggest that conditional cash transfers used to incentivize safer sexual preferences are potentially a promising new tool in HIV and STIs prevention. Additional larger study would be useful to clarify the effect size, to calibrate the size of the incentive, and to determine whether the intervention can be delivered cost effectively. Strengths and limitations of this study. This paper reports the results of a novel approach for HIV and STI prevention. You know, it really pisses me off when these papers repeat the same thing 3 fucking times within the first 4 paragraphs. Yes, we get it. It represents a new approach that you've already told us about for HIV and STI prevention. Come on, we're not blind. We saw it the first time you said it. Anyway, that's my 30-second diversion right there. Let's get back on track. Our study methodology is rigorous, and the results are likely to advance a global conversation about economic approaches to HIV or STI prevention. Our main outcome measure is the combined point prevalence of 4 STIs repeatedly tested by nucleic acid amplification tests over the course of a year and have been incontrovertibly linked to risky sexual activity. These biological outcomes, however, cannot be used to infer the relative importance of STI treatment-seeking behavior versus other behavior changes such as increased condom use or riskiness of partners. That's interesting. So what in simple terms I believe it's trying to say is that the biological outcomes of this paper can't necessarily separate the variables of how important the STI treatment the participants I've sort of messed up that sentence, of how important the participants consider to be the relative importance of STI treatment seeking behavior compared to other things such as whether or not they're using condoms more, or whether or not they're using partners that are more or less risky in terms of whether or not they have infections. So basically these are all sort of tangled up, and this measure of this analysis essentially can't tell them apart because it's only looking at the end outcome, which is how prevalent is your STIs. I'm sure some people find that relatively obvious, but I have to go through these things sometimes several times for it to actually sink in, so hopefully somebody will have benefited from my sort of interpretation of that. Anyway, the results reported in this study are limited to a 12-month experiment and cannot address the sustainability of improvements in STI outcomes over a longer period, particularly after the conditional cash transferred have been discontinued. So further to what I was saying earlier, obviously these are I wouldn't just even say professional, but also highly intelligent professors or whatever who are doing this study, and as you can see they seem quite switched on here to the limitations of their paper. They're telling you that it can't necessarily tell apart the different factors earlier that contribute to the prevalence of STIs. So as I was saying earlier, whether or not condom usage is a thing, or even how cheap it is to get it, that's not taken into consideration, or whether or not that changes over the course of their study. And the other thing, of course, is that it's not necessarily valid in the long run, anything longer than a 12-month period. So obviously they've accounted for these limitations, but as they've told us, there is nevertheless some potential here. They're saying that there's room for obviously further investigation as to how much exactly would be a good cost to run a program like this, and also how effective it would be relative to the bigger picture of the other factors that affect this kind of disease. So yeah, simply put, there are limitations, but there are nevertheless merits to this kind of solution. Okay, so introduction. Innovative solutions for AIDS prevention are desperately needed. The Joint United Nations Programme on HIV/AIDS reported that 5 people are affected for every 2 placed on treatment, and in 2009 approximately 2.8 million people were newly affected. Large-scale behavior change intervention large-scale behavior change interventions aimed at promoting safer sexual practices have proven less effective and more unreliable at stemming the tide of the epidemic than hoped. It has been far more difficult than was first anticipated to persuade high-risk populations to adopt safer sexual behaviors and practices that serve their long-term interests. Conditional cash transfer programs have become an increasingly popular approach for incentivizing socially desirable behavioral change. The principle of conditionality, making payments contingent, for example, on a minimal level of schooling attendance or preventive health care use, distinguishes conditional cash transfer programs from more traditional means-tested social programs. The evaluation of conditional cash transfer programs has shown that they can be effective at raising consumption, education, and preventive health care, as well as actual health outcomes. Similarly, contingency management approaches have shown important substance abuse reductions by conditioning rewards on negative tests for drug or alcohol use. In the context of the staggering social, economic, and human costs of the AIDS epidemic in sub-Saharan Africa, it is perhaps not as giant a leap as it would first appear to apply the logic of conditional cash transfers to the private arena of human sexuality, with the aim of incentivizing safer sexual practices among high-risk populations. Numerous studies have documented the responsiveness of sexual behavior to incentives, such as sex workers willing to forego condoms when clients pay extra, and increases in transactional sex in the face of household financial difficulties. Economic theory suggests several pathways through which risky sexual behaviors could be reduced by a conditional cash transfer program that conditions payment on negative sexually transmitted infection tests. Standard theory predicts that the incentives could operate by raising the implicit price of unsafe sex, risking losing the conditional cash transfer, or by bringing the rewards of risk avoidance much closer to the presence, e.g. a conditional cash transfer within weeks may be more powerful for some people than the specter of developing AIDS many years in the future, or both. If the conditional cash transfer was sufficiently large, then this higher income could also relieve economic pressures on young women to engage in transactional sex. But even if incentives were small, recent behavioral economics suggest that regular reminders of this new frame for viewing sexual behavior could still nudge individuals to overcome inertia and extricate themselves from unduly risky sexual relationships. In Malawi, small financial incentives have already been shown to increase the uptake of HIV testing and counseling. In the only prior study similar to ours, a follow-on Malawi intervention promised a single cash reward in 1 year's time for individuals who remained HIV negative, but this design had no measurable effect on HIV status. By contrast, we used the above theory to design and evaluate a novel intervention that tests for risky sexual behavior repeatedly over shorter time intervals, reinforcing learning about safer behavior with conditional cash transfer incentives each time. Methods. Trial design. The study is an unblinded, individually randomized, and controlled trial. It has 3 separate arms, a control arm with an allocation ratio of 50% and 2 intervention arms, low-value conditional cash transfer and high-value conditional cash transfer. Not trash transfer. That doesn't make sense. With an allocation ratio of 25% each. No important changes to methods were implemented after trial commencement. Participants. Inclusion criteria consisted of males and females aged 18 to 30 years and spouses starting at age 16 years and potentially older than 30 years, residing in one of 10 study villages within the Kilombero Ulanga districts of the Ifakara Health and Demographic Surveillance System in southwest Tanzania. The villages consisted of 8 rural villages and 2 semi-urban neighborhoods in Ifakara town, with participants evenly distributed across the villages. On average, across the 10 villages, approximately 20% of the 18 to 30-year-old residents were enrolled in the study. There were 3 exclusion criteria: being pregnant at the time of registration, having the intention to permanently migrate out of Ifakara Health and Demographic Surveillance System area within the next year, and unwillingness to participate if assigned to the control arm. HIV positives were eligible for enrollment. Interventions. The intervention arm was divided into 2 subarms. A low conditional cash transfer arm eligible for up to $30 over the course of the study, or 10,000 Tanzanian shillings, or approximately $10 per testing round, and a high-value conditional cash transfer arm eligible for up to $60, or 20,000 Tanzanian shillings, or approximately $20 per testing round. Those amounts were determined based on focus group discussions in neighbouring villages conducted before the intervention started, balancing sufficient incentive levels against concerns about scalability and potential coercion. All participants were tested for STIs at baseline, then every 4 months for 1 year. Participants in the 2 intervention arms were eligible to receive conditional cash transfer incentive payments if they tested negative for curable STIs at the 4, 8, and 12-month testing rounds. STIs tested at all these incentivized rounds were, the viruses again, I'm not going to read them out every time because that'll take like 5 minutes in itself, which are transmitted through unprotected sexual contact and therefore serve as a proxy for risky sexual behavior as well as vulnerability to HIV infection. Individuals in the conditional cash transfer arms were not eligible for the cash award at the 4, 8, and 12-month testing rounds if they tested positive for any of the viruses. Those converting from negative at baseline to positive at 12 months for syphilis or herpes were also ineligible to receive the 12-month conditional cash transfer. HIV tested was conducted at baseline and month 12, but payments were not conditioned on those results because of local ethical sensitivities. Genitalium results did not affect conditional cash transfer eligibility because there is some uncertainty around transmission pathways. However, it was included in the combined prevalence measure used as a primary outcome to increase the statistical power. Individuals in the intervention arms testing positive for any of the conditioned curable STIs did not receive the conditional cash transfer, but were eligible to continue as a study participant in subsequent rounds after having been treated and cured of the infection. Individuals in the control arm were not eligible for conditional cash transfer, but all other study procedures were identical between the control and intervention arms. Anyone testing positive for an STI, regardless of arm, was offered counselling and free STI treatment for self and partners through health facilities of the District Ministry of Health serving the research communities. Individual pre-test and post-test counselling was provided to study enrollees at each testing interval following Tanzania national testing guidelines. In addition, monthly group counselling sessions emphasizing relationship skills training adapted from a subset of the Stepping Stones curriculum were also made available to all study participants in all villages, but were not mandatory. Outcomes. The biological markers used in the study were selected both due to their likely prevalence levels in the study population and due to their status within the epidemiological literature as reasonable proxies for risky sexual behavior. In other words, these are viruses that indicate or are reliably indicators for, as they say, risky sexual behavior. The primary outcome measure, as defined in the study protocol, is the round-specific combined point prevalence of all 4 STIs that were regularly tested, at months 4, 8, and 12. This measure of combined point prevalence was constructed at study design to ensure sufficient power to detect differences in the control and treatment groups in response to the conditional cash transfer intervention. For logistical reasons, genitalium testing was not conducted at the baseline. We also tested for HIV, herpes simplex, and syphilis at baseline and month 12. All STI testing was conducted by Ifakara Health Institute Microbiology Laboratory in Ifakara. All test results were available within 7 to 10 days and were returned to the participants the following week. 10% of all samples and all positives were sent to the University of California Chlamydia Laboratory for confirmation analysis, i.e. quality control. Specimens for chlamydia, gonorrhea, were collected by a self-administered vaginal swab for women. Men provided a first catch urine, about 20 to 30 milliliters sample. Specimen collection among women was always observed by a nurse at a testing station. For men, the specialized receptacle used to collect a urine sample was provided only after dropping off personal belongings upon... You know what? I mean, obviously that's important if you want to understand exactly how the test worked, but like, this is quite a long section and I feel that it doesn't really add to your understanding of econometrics that much, so I'm going to actually skip through that because Obviously, that's stuff that's specific to this study, whereas we're obviously trying to read for things that are telling us about randomization and such. So there's now a little bit about sample size. I'm going to tell you they initially wanted about 3,000, but then later reduced it to 2,400. Jesus, this is reading so much faster when I'm skipping through sentences. I might actually do this for more videos in the future, partially because it's easier to read more stuff more quickly, and also because I feel more sinks in when I'm not just copying it word for word. But I'm going to decide whether or not I do that based on, feedback I get off whoever happens to listen to these videos, and them telling me whether they prefer me sort of casually reading or me reading word for word. And again, I might switch it up depending on the paper and whether or not it's relevant in that way. Again, this is a very early recording of me. Obviously, this is still technically week 1. It's Sunday, so I will no doubt become more refined and be able to switch between whatever modes are appropriate, whatever styles of reading are more appropriate, given the paper later on. And also I'll hopefully become more eloquent as well. But that's not the point. Also, I'll hopefully have a better mic. But that tangent aside, let's carry on here, but actually breeze through it a bit more quickly because I don't have all day and this isn't the most exciting paper. It is interesting for sure, but we don't need to know all the specific numeric details. Anyway, they presented the power of the ex post power calculations. I don't really know what that means. Okay, this is just some details of how they took the samples and so on, and they figured that 2,400 would actually be enough to provide at least 90% power to detect a 1/3 intervention-related reduction STI point prevalence. So essentially 2,400 people would be enough for them to successfully conduct their test and get results that would actually tell them whether the cash transfers have made a difference, as it says here, significant at the 5% level. And obviously, as you know from earlier, it says that it was successful, and they did notice that it did make a difference. So essentially, they're just proving here that it is statistically sound. Now then, this is an important part, no doubt. Randomization. This I'm going to read word for word. Individual level randomization took place at the study station after baseline interview and testing, with participants selecting colored balls from an opaque bag. The randomization took place in public view and in 2 stages, with participants first randomly selecting one of 4 balls to determine their allocation to the intervention or control arm. In order to study potential peer effects, in randomly selected sub-villages, the probability of selection in the intervention arm was 75%, 3 balls out of 4, and in other sub-villages, it was 25%, 1 ball out of 4. Based on the distribution of participants across sub-villages, we thus expected 48% of the overall sample to be randomized into the control arm. Participants randomized into the intervention arm were further invited to choose one of 2 balls from a second bag, determining in which of the 2 intervention arms, low or high value conditional cash transfer, they would be allocated. These highly transparent procedures were deemed necessary for the acceptability of randomization in a population with limited formal education. That's good, I respect that, because then you're acknowledging that they wouldn't necessarily understand, let's say, well, when I was at my university, I participated in some experiments, and obviously, the reason I participated in them is because legally you have to be given some kind of a financial reward for it. And again, it was a behavioral economics experiment where if you performed well, or rather, if your estimates of something or other were particularly accurate, you would get a little bit more money. So obviously I signed up for that, knowing that it was essentially half an hour of work for what was basically pretty decent money. So basically, here it shows that they're clearly tailoring the specifics of their experiment so that it's acceptable by the participants. Obviously, I'm not going to make too big a deal out of that, because obviously it's a good thing and there's no reason to dwell on it. But one of the things that I studied during my bachelor's was that sometimes there are experiments that I wouldn't say are unethical, but don't properly account for the cultural or social differences of the people who you're doing the experiment with, which is, I mean, at the very minimum, it's rude, and at the worst, it could compromise the experiment. So, obviously, doing things like that is important, partially because obviously you want your experiment to actually work, but also mostly because you don't want to be mean to other humans. Everyone's different, and you gotta acknowledge that. But anyway, that's just me trying to tell a little story and liven up this paper a little bit. Participants were not blinded to ARM assignments since awareness of their eligibility for the conditional cash transfer was a critical component of the intervention. Spousal pairs were assigned to the same intervention arm, and the protocol prescribed for randomization to occur after both spouses had enrolled. Statistical methods. Each individual was coded as per their initial randomized assignment as per an intent to treat design. However, individuals who were not present at any given round were treated as missing and dropped from the analysis for that round due to the lack of outcome data. We report sample means at baseline to verify the baseline across the 3 study arms. Unadjusted outcomes at the 3 follow-up rounds are reported using RRs, that is, the probability of being positive for any STI in the intervention arm, divided by the probability of being positive for any STI in the control round. RRs are calculated from logistic regressions using the margins and nullcum post-estimation commands in Starter v12 statistical software package. We further report adjusted outcomes using RRs to account for the residual variation across arms after randomization. Adjustments have been made for standard socioeconomic variables such as gender, education, age, marital status, income, socioeconomic status, sub-village, and baseline STI status. Age and income are continuous variables, while the other adjustment variables are categorical. We cluster SEs both at the household and sub-village levels, accounting for the possible correlation within couples and the variation in selection probability at the sub-village level. We present a subgroup analysis by gender. We used Starter version 12.1 for statistical analysis. Let me just check how much of the paper remains. A fair amount, actually. Actually, let me double check that. Yeah, I'd say a good 20 to 30 minutes more, actually. So don't necessarily listen to all of this in one go. But again, it is due tomorrow, so I frankly should have uploaded this sooner, otherwise people might not necessarily benefit from it. But if you're staying up late tonight, then you'll probably be able to listen to the whole thing if you so desire. Or you can listen to it on the bicycle on your way to uni tomorrow. I don't know. But either way, it might be helpful for you. So I'm going to keep talking and keep recording. Results. Participant flow. A total of 5,370 individuals were randomly selected from the Ifikara Health and Demographic Surveillance System sample. 864, or 16.1% of those individuals, were not found. Some of them had migrated and stuff. I'm not actually going to read out all of the numbers because, frankly, I'm not going to remember them. You're probably not going to remember them unless your memory is insane, and neither of us are probably going to care for the exact numbers. What we want to know here is, obviously, how to do a regression, and also whether or not this is an effective thing. The exact numbers themselves aren't important in their own right. It's their significance that is important. So we're going to skip through and try and find that. So obviously some of them didn't meet the inclusion criteria, some of them explicitly refused to participate. These are all percentages that are less than 5 for the record. Okay, so in the end there were about 2,400 remaining. They tried to get 3,600, but 1/3 of those didn't come to the study station for registration. So yeah, as it says, they ended with 2,400. Half went to the control arm, and the other half went to the cash transfer arms. Okay, so there's some more percentages. Half went to the, well, of the half that were in the test, of the half that were in the test half, I mean, I don't know what other way to say that, a further half of those were put into the high value cash transfer arm, and the other half into the low value cash transfer arm. So obviously a quarter of the total each. Okay, so at each stage, it describes that at each of the months, some people dropped out, quite a significant number actually. I'd say, yeah, anywhere between 5 and 15% dropped out overall. There's a number of different numbers depending on which cash transfer arm they were in and which month it was and so on and so forth. But it's basically saying something called attrition, which I believe they spoke about last week if I remember correctly, so you'll already be familiar with that, I think. So yeah, because of attrition, some people were lost at each round because they didn't want to turn up. Okay, so let's move swiftly forwards. Recruitment. Recruitment and baseline data collection took place from the 10th of February to the 9th of April 2009. The second, third, and fourth rounds of interviews and testing took place from the 9th of June to the 15th of August 2009. And, well, some other dates, again, this is stuff that isn't necessarily specifically important, blah, 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 respectively, ending in 2010. So between the beginning of 2009 till the beginning of 2010, those 12 months. Okay. Process. The intervention was well accepted and assessed by the study participants as indicated in the participant flow and the low attrition numbers. Furthermore, study participants randomized into the conditional cash transfer arms declared that the financial incentives motivated them to modify their behavior. In the high-value conditional cash transfer arm, 317 or 59% declared that the money motivated them very much to change their behavior, and 67 or 12.5% stated that it motivated them somewhat. In the low-value cash transfer arm, those numbers are instead 37% and 20% respectively for very much and somewhat. So that's a total of about 72.5% for the high value arm, and a total of 58% for the low value arm. So 58 and 72. So that obviously in both cases the money influenced them somewhat, or at least they perceived that the money influenced them somewhat. Let's see here. Okay, so I mean for this one you're probably going to want to have the paper open, as there's a table showing the baseline characteristics of the participants by study arm. Now, obviously, these tables are, they've got a lot of numbers. If you haven't looked at econometric tables before, it can be a little bit daunting, but I vaguely remember this from my undergrad. Again, I have to emphasize, economics was not my strength, even though I did it and I understand it to a vague, like reasonable degree. I am not going to be the best explainer of these things until I've refreshed my memory and or relearned stuff. But anyway, I'm going to do my best. To my understanding, Table 1 shows three groups. The control group, the high value cash transfer group, and the low value cash transfer group. And then it shows the effects of each of these, being in each of these groups for different traits of the participants. So for instance, the first one it says is female. So the percentage of female people in the control group was 49.9. For the high value cash transfer it was 51.1, and so on and so forth. So as you go further down, it's essentially, I think the point of this table is to show that it's relatively equal for all of the groups. So the percentage married, for instance, is around 75% for all the groups. It's the percentage of having primary schooling is also around 70 to 80% for all groups. And then the percentage having, obviously, the diseases and so on are similar for all the groups again. And, well, I'm going to close the table now because that's about the extent of it. Oh, it's the average age is also similar for all the groups. So, yeah. They verify that there was no deviation from protocol that could have led to differential secondary spousal enrollment across arms. La da 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 da. Okay. Again, I'm not sure if I said this earlier, but the reason why I'm skipping a lot of the sections is because I don't feel they're relevant to what we're trying to learn here. Obviously, this is an interesting paper in its own right. Most scientific journals are, but we don't have time to read all of the ones in the world. Also, because I'm reading all of this out loud, my voice is getting slightly sore, which in the long run will be fine as my voice naturally adapts to talking more than I usually do. But in the short run, obviously, I will there's a limit to how much I can read out loud in one day. Because it's frankly, I mean, if you look at the length of the recordings, I'm basically talking for an hour straight at a time. I have little breaks, which obviously you don't notice because I cut those out, but only for a minute or so where I take a drink. Sometimes I don't cut them out, like right now. Anyway, so I'm trying to read only the relevant bits of information and and provide an explanation for anything that I can understand, but I think others might not be able to. Equally, there are going to be some sections which I literally just do not have a clue what's going on. These will particularly be the bits with advanced econometrics, because that's not fun for me, in my personal opinion. So if others could explain it to me, I'd be very grateful. But equally, I will do my best to obviously provide some manner of rephrasing, because often they tend to use extremely technical language that isn't really friendly. I'd say, especially if English wasn't your mother tongue. I happen to be lucky and be born in the UK, so it's fine for me. But I personally, if I had to read everything in, let's say, I don't know, French or Spanish, I'd find that really annoying because I'm not as familiar with those languages as I am with English. So if it's at all helpful for me reading these things with, frankly, simpler, easier to remember words, even I, put it this way, even I as an Englishman prefer to try and simplify these words in my head, because long words just don't stick in my head. You can call me unintelligent if you want, but I remember things much, much better if I explain them in simple terms. Even if I explain something complex in loads of simple words, I will always remember that than if I explain it in a few but very complex words. So that's essentially what I'm trying to do here. Furthermore, I believe that none of you are going to want to rely on me alone. I am going to do literally all the readings from now on as far as I can, but obviously I would expect that nobody's going to want to rely on me alone. You're going to want to read these papers yourself, because I am a human. I'm capable of making mistakes or whatever, or perhaps you just don't like the sound of my voice, or maybe you just prefer to read a book anyway. You just want to have these audio recordings as supplementary material to help boost that, rather than relying on it alone. So there's lots of reasons not to just listen to my recordings. A, because if I'm ill or something, I'll stop recordings that week. Or B, because obviously some of the stuff just doesn't really translate, especially equations and such, to audio recordings that well. So yeah, I will do my best to try and make it different from the actual text itself in a way that omits information that isn't necessarily useful to us for the cause that we're studying, Not because I think it's not interesting information, but because I think it doesn't directly relate to the lecture that's coming up. And because, as you and I'm sure, are both aware, it's going to get much more reading heavy as the term goes on, and I want to still have time to be able to read everything out loud, and therefore it means that I will have to read only the most relevant parts of each document. Because frankly, even if I wasn't reading out loud, even though I was reading just by sight reading, using my eyes and not my vocal cords at all, that would still take a really long time if I read every. So what I essentially intend to do, and I've already been doing a little bit in this paper, is skim reading using my eyes ahead of what I'm actually reading, and then skipping things which I don't think are directly relevant. Now, again, obviously I'm using my judgment here, and you may not necessarily agree with what is and exactly isn't relevant. You may have slightly different thresholds for that. If you're a super fast reader, you might read everything anyway. If you're a slower reader than I am, which I bet you're not, because I'm a really slow reader, in that case, you might want to actually listen to my stuff more, because then you'll have more time to do your own readings for other papers that you either are more interested in or think that you need to find out more about. So this, obviously I'm not talking about the paper right now, but obviously as this is among my first few recordings, I'm still very much all ears in terms of how you want me to go about this, because I intend to do these recordings no matter what, but I don't really intend to listen to my own recordings that much because I won't have the time to that. From my perspective, I benefit from doing these recordings because I learn things better when I say stuff out loud. I can't sit and read a book on economics or on anthropology or whatever. I can't read academic text without going insane. So I read out loud to obviously make sure I'm doing something, and also because I'm like 99% sure there's a paper or a bunch of papers or whatever saying that you memorize stuff better if you read it out loud. So that's why I do that. But for you, obviously, maybe you read it out loud too. But if you don't, also hearing it in addition to reading it is obviously presumably beneficial. Again, assuming what I said earlier about you not hating these recordings. They will go up in quality, I promise. I'm hoping they're decent enough to listen to already and not put you off. But the point is that, yeah, I am open to suggestions as to how you want me to go about doing these. I personally wouldn't really want to read everything word for word because it would absolutely obliterate my vocal cords, which I'm not a fan of. But I would absolutely love to hear whether or not you want me to do my little explanations, whether you want to hear my little side stories so that I don't go absolutely insane when I'm doing these, or more insane, arguably. And last but not least, I don't have any last but not least point. The first 2 points were good enough on their own. So yeah, those are my points. And I'm now going to try and finish this, but there's actually not much left of this paper, so if you stopped listening as soon as I started rambling, that's okay, because I've already read the bulk of this paper. If you're still here, then what I've just said is, in fact, irrelevant, so let's carry on. Okay, so they analyzed some numbers, and they found that the reductions in sample size due to missing data are similar when using... Okay, so hang on. In order for any of what I just said to make sense, you've got to look at tables 2 and 3. So they've got outcomes which are unadjusted, and then afterwards they've got a second table, table 3, where they have adjusted them. Now, what have they adjusted them for? Again, this is one of my weaknesses personally. I take a long time to digest numbers that's just fucking thrown at you in a table. So obviously I will do my best to interpret it, but it's going to take me a moment to understand that. And I don't have the time, unfortunately, to go through and edit all of my recordings. So usually when I say, okay, sorry, I'm just going to look at this and try and interpret it and understand it for myself, I'm just going to go through it in my head, and there will be a pause for about, I'd say, 20 to 30 seconds while I'm actually interpreting that. There will be silence during that time. I appreciate that from a entertainment perspective. It's not going to be that nice to listen to dead silence, but I hope that you can understand that I can't really read these things to you if I don't understand them myself. So that is what that pause is there for. So I'm going to be silent for a second now. Okay, so as far as I can tell, correct me if I'm wrong, I think they're just adjusting for the number of people, because they're removing some people at round 2, 3, and 4 due to things like missing on covariates in the logistic regression model, it says. So as far as I'm aware, their sample size is essentially changing, so they've got to adjust for that, and they've got a table for their results without adjustment, and they've got another table for their adjustments, because I think basically, as far as I can understand, they need to keep the same balance of gender, education, age, marital status, income, socioeconomic status, blah 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 blah. They need to keep the same mixture in all of the test groups in order for in order for it to be statistically robust. So they've had to change their samples when people left the group, obviously, because that would affect that. So table 2 is without the adjustment, and table 3 is when they've brought it back into the same balance, so that all three groups, the control group, the high cash transfer, and the low cash transfer, all have the same balance, as I said, of gender, education, and the other traits. That's my understanding of it. Again, I might be wrong, but I'm pretty goddamn sure of this one. Obviously, correct me if you think otherwise. So finally, there's outcomes and estimation. We kind of already, that was mentioned in the introduction, obviously. So yes, it does have an effect, it turns out. I'm not going to spend too much time on that because we're not going to memorize these numbers or anything. These aren't going to be tested. But the point is that they ran a regression. Obviously, they had to control for everything to make sure that they really were looking at the effects, and it wasn't being affected by anything else, which is why obviously all the groups had to be balanced in terms of the people within them. Okay, so at month 12, for example, I am going to read some of them out loud, because otherwise this is just abstract knowledge about regressions, which isn't really going to sink in. And we do want to know a little bit about this, because it's obviously a very important topic. It's a disease that is... I mean, you don't need me to tell you. You're educated people, and you know of how important analyses like these can be. So the results are that at month 12, shown in column 3 obviously, for the combined prevalence of the STIs tested by the nucleic acid amplification tests, the adjusted model estimated a 27% reduction in the RRs for the high-value conditional cash transfer arm compared to the control arm. 27%, you probably don't need me to tell you, that's fucking huge. So obviously, they're not kidding when they say this kind of a test really has huge potential. However, for the low-value conditional cash transfer arm, the RR is not statistically significant. Okay, so I've read the rest of that paragraph, and I believe I've said everything that's relevant, so we'll move on. So, discussion. After 12 months, the adjusted results showed a significant reduction in the combined point prevalence of the 4 curable STIs tested by every 4 months by acid amplification test in the group that was eligible for the $20 quarterly payments, but no such reduction was found for the group receiving $10 quarterly payments. Such results were not found at earlier rounds nor for adjusted results. Furthermore, the impact of the conditional cash transfer did not differ between men and women. Limitation. Our main outcome measure is the combined point prevalence of 4 STIs repeatedly tested by nucleic amplification tests over the course of the year. Hang on, I've lost my place. Over the course of the year, and which have been incontrovertibly linked to risky sexual activity. These biological outcomes, however, cannot be used to infer the relative importance of STI treatment-seeking behavior versus other behavior changes, as it said earlier, such as increased condom use or the reducing the riskiness of partners. Furthermore, the lack of a clear result on the combined measure for the 3 STIs that were detected by serology only at baseline in month 12. This measure primarily reflects herpes simplex virus 2 incidence, as HIV and syphilis prevalence were somewhat lower. That is puzzling, and it merits further study. The contrasting relation with the impact of the high-value conditional cash transfers on the 4 curable STIs that were tested by nucleic acid amplification tests could point to the importance of treatment-seeking behavior rather than safer sexual practices. However, the interpretation of herpes simplex virus 2 results is complicated by the fact that most transmission occurs via asymptotic shedding by partners who may be otherwise low risk, as well as the fact that it can be transmitted even in the context of appropriate condom use. Furthermore, this study was not powered to directly examine HIV conversion, thus implications for HIV prevention remain speculative. In order to study potential peer effects in randomly selected sub-villages, the probability of selection in the intervention arm was 75%, in the other villages it was 25%. This might have led to baseline imbalances. For this reason, we included sub-village indicator variables to the adjusted models. This might explain some of the differences between the results from the unadjusted and adjusted models. Finally, the results reported in this study are limited to a 12-month experiment and cannot address the sustainability of improvements in STI outcomes over a longer period, particularly after the conditional cash transfers have been discontinued. Nor can they address the possibility of adverse consequences to the extent that extrinsic incentives may reduce the long-term intrinsic motivation to engage in safe behaviors after incentives are withdrawn. To address these questions, we will follow up with study participants 1 year following the end of the intervention study in the spring of 2011 to assess whether improved outcomes have been sustained or reversed in the absence of a positive feedback mechanism in the form of STI testing and conditional cash transfers. I wonder if it's possible to get the 2011 paper up somewhere, or whether that's even been published. I would assume it has. There's no reason for it not to be, but maybe that'll get mentioned in the lecture. That would be interesting, certainly. Generalizability. While this study's results are important in showing that the idea of using financial incentives can be a useful tool for preventing HIV and STI transmission, it remains an initial study on a limited scale. Even though the study site is fairly representative of rural and small-town environments in sub-Saharan Africa, this approach would need to be replicated elsewhere and implemented on a larger scale, in permutations requiring less administrative and laboratory capacity, before it could be concluded that such conditional cash transfer programs offer an efficient, scalable, and sustainable HIV prevention strategy. Interpretation. The results indicate that conditional cash transfer based on negative results of periodic screenings for incident STIs, an objectively measured marker for risky sexual behavior, are potentially useful tools for STI and possibly HIV prevention. The extraordinarily high social and economic cost of the current HIV and AIDS crisis suggests that prevention can be far cheaper than treatment, thus motivating the continued search for innovative and effective new prevention approaches such as conditional cash transfers and other financial incentives. The absence of significant impacts at rounds 2, month 4, and 3, month 8, suggests that the impact of the conditional cash transfer may take time to materialize, perhaps because it is not easy to extricate oneself from the complicated sexual relationships, or perhaps because participants needed time to become accustomed to and trust the incentive mechanism. The comparison between the impacts of the conditional cash cash transfer intervention in the high-value conditional cash transfer arm to that in the low-value conditional cash transfer arm permits us to better understand at which threshold conditional cash transfers can be effective as an HIV and STI prevention tool. While the results showed a significant reduction in STI incidence in the arm that was eligible for the $20 cash transfers every 4 months or up to $60 over 12 months, no such reduction was found for the arm receiving the $10 conditional cash transfers every 4 months or up to $30 over 12 months. This distinction must be interpreted with caution, though, because assignments were not masked. Hence, individuals in the low-value conditional cash transfer arm could have behaved differently than if they were to receive the same incentive in the absence of a higher conditional cash transfer arm. Both of these amounts represent a meaningful proportion of household income in a country where the gross domestic product per capita was $440 in 2008, and particularly among our study participants who had mean annual individual earnings of approximately $250. That is the end of the paper. I will stop the recording here, and I will see you in the next one.